Today's an interesting day. Today I'm here with Gordan, who is one of our patients. And Gordan, you had the correction done 4 weeks ago today.
4 weeks ago exactly, yeah.
4 weeks ago exactly today. And you went straight to LTP, and I talked to you through why it was necessary for you. And I also told you that it's always been the dream to be able to do this, but technology didn't allow me to do this. And you know, I've shown you around the ecosystem, you know how much we invest in the technology and how we want to make things super accurate and super predictable for our patients, because, you know, it's a big deal for everyone we treat, and we only want to do it the once. So I want to take you for a trip down memory lane, if you don't mind. So this was your old reality. You have to look at it, Gordan, I'm afraid.
Yeah,
I know you don't want to, but you have to look at it. And this is what was actually going on inside. Now, I know we get a lot of comments on the group about gaps, right? Well, I've said this before and I'll say it again. Nature engineers these gaps in between natural teeth for a reason. Because the reason all this is shiny is because of the best mouthwash known to man, which is called your saliva. And if it can't get through these nooks and crannies, it cannot fight bugs. So if you close the gap, then actually the bugs still get in because they're on the nanoscale. You can't see them without a microscope. But now the saliva can't get in and do the cleaning, and neither can your water pick, and neither can water, neither can a cup of tea. Nothing can clean it anymore. So there's no magic here. And you had all these gaps before. You had them when your teeth were healthy, you had them when your teeth weren't healthy. The gaps got bigger as it became unhealthier because the body was desperately trying to create a cleaning gap. That's what it tries to do. So we know this in the strategy that we use, that if we don't establish a cleaning gap, the body's just going to create an unpredictable one anyway. So we'd rather engineer it in from the beginning. So the cleaning gap is good. We call it the engineered cleansing space. It's good. Now, you've been living with this for 4 weeks. Does your mouth feel dirtier than it did before, or much healthier than it did before?
Yeah, it feels much kind of cleaner.
Cleaner.
Yeah.
And you can tell that immediately, even though in this picture you had a lot less teeth, and you've got twice as many teeth as you had when you were here. But you're telling me that this felt like it was not only retaining food, but it was retaining food to a point that you found it difficult to remove it all, correct?
Yeah, that's right.
Whereas with this, it's clean.
Yeah.
Right? Okay, so that's good. So let's move on to the next one. So this is you in motion. And what these clips are the dentures you used to wear, correct? Tell us all how much you hated those.
I used to wear dentures for almost 5 years. There are a few things that I hated about dentures is they retain so much food, so I have to clean constantly. But in the evening, before I went, I wanted to brush my teeth, and I used to close the door of the bathroom so nobody can see me taking the dentures out, and that clinging sound when dentures touch the sink is still in my head. And I
shouldn't laugh. I know it's a serious thing for you guys.
Hated that.
Yeah.
Obviously, I didn't want my wife seeing me with the dentures out and all that. So yeah, not very pleasant.
Yes. So this was actually the intraoral scan that we stuck in 3D of what you actually had. And we can see things had moved, they'd drifted, they'd broken, they'd tilted over like that, they've moved away, the gum has receded here, the bone is all over the place. There's active disease going on. So when we are analyzing you, we're not just looking at the roof tiles. We're analyzing what's going on underneath here. And what we found going on underneath here was this. And you have to understand the level of thinking that we're applying to this. We're not looking at it and let's have some pretty teeth level. Our criteria is always the same. We are a group of clinicians, and clinical criteria is first and foremost eliminate disease and secondly stabilize function. If I was to draw a pie chart, It's 90-95% of what we do. Somewhere along the way, people get it into their heads that what we do is cosmetic. What we do is not cosmetic. What we do is health-based. So this active disease, as we can see from this video, what is going on here is very simply, you can see where it's like moth-eaten in these areas compared to, let's say, the chin, which is a lot more solid in color. This, for us, is active disease. We have to clear all of this out, and we can only put implants into healthy bone. And when we put implants into healthy bone, we want to stabilize them. If I put 4 implants in, like this, what we had previously, what we couldn't do, was we couldn't introduce a splint to hold them all together that was rigid. And we couldn't introduce that splint immediately because of the fact that our guides were helping us work to about 100 micron accuracy. So we knew something. We knew that if we could get the accuracy to less, if we could get the accuracy to 50 microns, then maybe, just maybe, we can introduce a metal bar immediately to hold those implants far more stable than if we just put a deprogrammer, which is all polymer, to begin with. And we also know that if we introduce this metal bar, we can actually deprogram people into the correct bite and give them a full bite, and they're adapting to all of it right from the beginning. So you've had a full bite. So you haven't just had contact here at the front, you've had contact all the way around to the sides, correct?
Yeah.
Has it caused you any discomfort?
No.
No.
No, everything's good.
We also know that on top of this rigid splint, which is the bar, we've got the veneer itself, which is the PMMA, and we can deliver both in one go. And that is actually the LTP. And then we engineer in a cleansing space here. And that varies from individual to individual. So the more active the disease and the more bone they've lost, the bigger the engineered cleansing space we want to put in, because our criteria is, will it still be there 30 years from now? So I think people are worrying about the gap when it's actually an engineered cleansing space that we're actually putting in on purpose. It's not a, I like it, I don't like it. It's a, I need it. We believe you've got to have it for longevity. Now, one of the things I want to clear up, and you did a lot of homework before you came to us, didn't you?
Yes, that's right.
Okay, and what was the things you were being told that was very different to what we did?
Well, I think that was the problem, because I haven't been told anything specific. And
it's all woolly.
That's the problem. Right. So I haven't been told what I should be doing in the future, and what I'm actually, what is the plan for me.
So what was the advice? What was the plan then?
The plan is, let's see and wait what's going to happen with your condition. And
But it's only going to get worse.
That's not a plan.
As it did.
Exactly. Yeah.
Right, and the worse it gets, the less we have to work with. And then when we get to the point where we have to do a correction, we have to work in healthy bone. We have to stabilize as soon as possible. There's nothing more stable than LTPs. But again, it's not a one-size-fits-all. Every single patient we treat is totally individual in both their biology and their mechanical requirement. So just because one person had it done one way, everybody going, oh, well, I'm having it done a different way, it must all be wrong. I think this is part of the problem that we get into. So your treatment plan is incredibly specific to your biology, your physiology, your biomechanical needs, your physics. We have to work that way, and it can't be the same for someone else. It'll never be identical. I don't think I've ever treated 2 people with exactly the same parameters ever, and I've done thousands of them, okay? And so is Isabella. She'll tell you exactly the same thing. So have all the other surgical clinics. They'll tell you all exactly, no 2 patients are the same. So to think that we use the same strategy for everybody, and people will have noticed that we're taking more people to LTP now, and there's 2 main reasons for that. Previously, we didn't feel confident enough without this level of engineering to even take them to deprogrammers and then LTP. They're the patients who had higher complications. For example, they're the ones who are more likely to lose an implant in the healing phase, which meant revision surgery. We want to nullify that and get it as close to zero as humanly possible. Number two, they're the ones who had more movement of the prosthetics. Have you had any movement of these prosthetics at all since we fitted them?
No, not that I noticed.
Main reason being we've got a rigid subframe and we can tighten those screws to much higher than we could if it was a deprogrammer. That's just a fact. These are laws of mechanics. It has nothing to do with biology. It's all about mechanics. And you can do more things mechanically when you're using things that are more predictable and far more stable. And the other thing for me was, this is a one-time event for you. Now I have the ability, we as a group have the ability to calculate things to a much higher level than I could do 10 years ago. But interestingly, did you know that we were actually taking people straight to LTP 10 years ago? But the way we did it then is very different to the way we do it now. We had patients who had the extent of disease that you did, and it was not safe to put them with anything that flexes even by 200 microns for even the shortest period of time, because it was greatly increasing the risk. So what we used to do with those patients is we used to have what we call the 24-hour to 72-hour protocol. And that was the time that was needed after surgery to design and manufacture a rigid framework prosthesis, our current LTPs. So 10 years ago, what I would have said to you was, okay, we're going to do your surgery, and then what we're going to do is 24 hours later, you're going to be with no teeth for 24 hours. My experience of this is it's soul destroying for people to live with no teeth even for 24 minutes, let alone 24 hours, okay? Yeah. And for those poor sods where we had to run it to 72 hours simply because of biology, where, you know, they had some bleeding factor that we needed to control medically, so it wasn't safe to put it on at 24 hours. 3 days with no teeth. But the interesting results with those people from 10 years ago, when they went straight to LTP at 24 hours, when I looked at the audits from back then, when me and Isabella were looking at our own audits, our stuff, the stuff we do, not what anyone else does, because we were doing big volumes of these, hundreds and hundreds of cases every single year, we noticed that these people adapted quicker, their gum tissue was a lot healthier, their implant resonance was a lot more stable and a lot faster, and they had a lot less complications. Not that we have many complications now, but if you're a patient who has a complication, you'll wish you were like all the patients who didn't have a complication. So we're always trying to drive down complication risk, but now the technology allows me, instead of 24 hours, I can actually pre-make the LTP because of the accuracy of the guide and because of the engineering that you've seen over at our bioengineering division. So we've got some of the most advanced milling machines that exist. Because of this quality that we can quantify from the beginning, we can now fit the LTP straight away. We couldn't do this. I've gone through 2 years worth of testing to get it to this point, and now the main reason for its existence is we can help a lot more people a lot more predictably. And the mandate of 21D has always been the same. We are here to help as many people as possible. So I saw on the group, and I know you've been dealing with some of this, some people have said that we are shortcutting. Is that correct?
Yeah, that's right.
Do you feel like you've been shortchanged?
No.
Okay.
Absolutely not.
Okay, and let's talk about the 4 weeks that have gone by. You had the swelling in the beginning, you had the temperature, you felt a bit weird first 20, of course, you had surgery, big surgery, we had to clean all this out. Yeah. So the natural physiology of the body, all living human beings have something called the inflammatory cascade, which is temperature, swelling, and pain. And it's mainly controlled by lots of fluids, plenty of rest, and my personal favorite, lots of ice cream, which is very good, right?
Yeah.
If ever there was a good reason to eat a lot of ice cream as a grown adult, it's that one, right? How did you feel after a week?
After a week, I felt really good. There were no bruising, no swelling after a week. I was starting to eat food and good.
And you said we're 4 weeks in today, and you said something funny to me before we started filming. What did you try and do yesterday that became an old habit?
Yeah, I was going in the bathroom and I went like, I'm going to take my prosthetics out.
Well, you thought you still had dentures.
Yeah, yeah.
Okay.
So that was it's just one of the things automatically you do, but obviously that's not happening
Yeah.
anymore. So.
Don't ever try and do that. Ever. Okay, because A, it's not going to work. And B, that's like crazy. But notice that conditioning. This is that adaptation thing I talk about. So when you've been a certain way and doing a certain thing for a long time, then it can get weird when we move this fast and even the brain hasn't figured out that we're in a whole new reality and you go and do something that you've been doing on autopilot for 5 years. But that is the other thing about introducing LTPs early. What we notice with all the patients that we've used where we've been introducing LTPs early, and we've told them all and we've told them why, is they only have one adaptation cycle, not two. So they're not adapting to a deprogrammer and then adapting to an LTP. They're just adapting to the final place. And I'll tell you why that's important. So I'm just going to pull this model here. I don't know whether you guys can zoom in on this. So this is the mouth of a human being. So this is a cross-section of a person's head. The vast majority of the space of the mouth is occupied by this thing called the tongue. And then this is the lip. And you see this little white thing here? These are the teeth. It's this and this that has to do all the work for adaptation, but we're only working with this. Okay? So when we change anything in here, so when we make a big change, like we move it either way by 1 millimeter or 2 millimeters, this and this feels it. But the clever bit about this kind of biohacking is because everything swells straight after surgery, you know when it shrinks back down? Mm-hmm. The brain thinks that wherever I put it is where it's always been, which is why you're adapting much faster. Now, I know you didn't go through the deprogrammer pathway, so we choose. Do we put you through the deprogrammer pathway or do we take you straight to LTP? We have clinical reasons to do it. It's a clinical decision. It's not a patient choice, okay? It's a clinical decision because we want engineered safety as quick as possible. And there's nothing quicker than immediately. So now we're there. We can do that. We're the only people in the world, as far as I'm aware, who can have the pre-made long-term prosthetics ready to fit immediately after surgery, which is probably why you haven't heard about it anywhere else, because it's not my fault that no one else is doing it. It's what we're doing, and it's based on the science of this. Now, here's what's interesting. The other interesting thing is when I watch your video, these are the gaps that you had when you didn't have your dentures. And your tongue learned to live inside these gaps. So I just want an honest answer. Did you bite your tongue in the beginning?
Yeah.
Has it stopped doing that now?
Yeah. Yeah.
Because it's adapted to the new space.
Yeah.
That's another thing that instead of it taking months and months and months and months to adapt, we do it during the healing phase. So that's the other reason to introduce the long-term prosthetic. So we know that patient adaptation is smoother. It's quicker. It's not gone. It's just quicker. We've noticed that with all the people. And what does the future look like? In my view, if this level of engineering is already here in 2025, then I can see that the future is that it's to LTP in probably 80% of patients or 90% of patients. I know everybody's looking for the same procedure for everybody. Well, when everybody looks exactly the same, that might happen. But when you all look different, that's never going to happen, not in my lifetime, not when you're all different sizes, shapes, ages, biologies, physiologies. We still have to calculate every single one based on individual need. And if I move along from this, this was your static start X-ray. How many years had you not had teeth in these regions for?
It'll be about 4 or 5.
4 or 5 years.
When I started to get dentures.
Started to get dentures, right. So now we move to the new reality. This is Gordan now. This is the great thing about Gordan's smiling video. He's still not comfortable smiling. Not 100%, isn't that right?
Yeah.
Still feel a bit weird? Tell me why.
Because I always kind of covered my mouth or didn't open the mouth when I was smiling.
But were you like that when you were 21?
No.
Right, okay.
So
right.
at some point, I I didn't feel comfortable smiling.
So I call this the Elvis smile. You know, the one where you're not quite sure and it's all of it going everywhere. But don't worry, you've had those moments already. So I can see you smiling at me where you're not conscious of this at all. And it's very normal, okay? But this here, when somebody's pointing a camera in your face, which you hated for 5 years, the old guy came out. This is, again, the adaptation process. This is some photographs I had my clinicians take today of gum health. If I really pinch and zoom this, this is the real miracle of biology. If I provide it with a healthy foundation, if I provide it with the ability for saliva to transmit, and you see all these bubbles? Can you see them? Yeah. That's saliva. That's how I know that my engineered cleansing gap is doing the job. And that engineered cleansing gap varies from person to person that we engineer in. So in some people it'll be 0.5. In some people it'll be 1. In some people it'll be 1.5 millimeters. In some people it'll be 2. I've even engineered in 5 millimeter gap, half a centimeter gap, for patients who are in their 80s who cannot move their fingers anymore because of arthritis. They can't even pick up a toothbrush. So I need cups of tea, water, and the body to clean it all. Yep. Because I can't get a toothbrush in. These are realities. So this engineered cleansing gap is a clinical decision. It is not a patient choice, and we're not shortchanging anybody. If anything, we're doing the opposite. You're getting the iPhone 27, right? But the real beauty there is look at the stability of your bite. Look at how beautifully stable it is. When was the last time all your teeth lined up like this?
A long time ago.
Okay, but 4 weeks ago, we put it back in 2.5 hours, and you've been living with it. Yeah. Right? But it was a long time ago since it was last like this. And it's been degeneration slowly for a very, very long period of time, and we did that. I want everything in our favor so that you never lose this ever again. So all the clinical advantages I can use, we will use. Okay? Now this might differ to strategies that others use. We will not accommodate other people's strategies in 21D. We're people who've done thousands and thousands and thousands. We know what works, we know what doesn't work. And this is the strategy that we as a company have settled on, and we are not going to change it for anybody because we really like the safety profile of it for our patients. There are other people who will make all kinds of other claims of what they can do. That's fine. Look at this tissue here. Can you see this gap? Yep. But look at how pink the gum is. If you want to know what healthy gum is, look for pink. When it's red, it's not healthy. And the reason it's that pink is because saliva can get up and under. Now people go, oh, I'm getting food stuck up there. Well, I've got all my own teeth. I get food stuck. So I've got two choices. Clean it or don't eat. I prefer to clean it because the don't eating thing doesn't work for me, as you can clearly tell. This is your new reality. 1, 2, 3, 4, 5, 6, 7, 8. Solid. And this went straight in on the day of surgery. This is from the day of surgery. This is what Isabella did for you on the day of surgery. And she also gave me feedback when she reviewed you after, was it a week?
Yeah. Week.
Her exact words to me was, Vijay, I've never seen such good healing in 7 days ever before. Which is a big deal considering this woman's been doing it every single day for the last 15 years. She's seen a lot. And this is where you started. Look at that. And look at your engineered new reality. This is where we have to be, because this has to be there when you're 80, Gordan. I insist, otherwise I'll be annoyed, very annoyed, because I don't want to have to treat you again. I hope you understand that that comes from a good place, right? So this is the understanding of why we move patients, some patients, to LTP. And actually, from the evidence that we are seeing, and we're an evidence-based company, we think more and more people can be helped by using the straight-to-LTP methodology. You don't have to have it done with 21D, but 21D will not change its clinical profile protocol of safety and stable function over the longest period of time. That is not up for discussion. These are clinical decisions, and you will want us to be right for you, and we're not going to change that. Are you glad we're like that?
Absolutely.
Good, I'm glad. So thank you very much, and I hope this helps clear up some stuff about why we go straight to LTP in patients now.